Hello, everybody. I'm Rhiann Vandrew. I'm a partner at Mills & Reeve. We're legal advisors in the health and care sector. Welcome. If you're not here for the Black Country ICB and Walsall Together case study, you need to go out of the room and go back there. Great, we're all good. I'll tell you a little bit about what the plan is for this afternoon, but before we do that, I'm just going to ask the panel to briefly introduce themselves. You want to kick off?
Hi, I'm Michelle McManus. I'm Director of Place Development and Transformation for the Walsall Together Partnership.
Hello, I'm Kerry Ord. I am the Executive Director for Adult Social Care, Public Health and Hub at Walsall Council. I promise I don't always have a glass of wine in my hand.
I love that photo. It's my favourite one.
I'd own that.
I'm Connie Jennings. I'm the Director of Stronger Communities for WHG, who are a community place-based housing association in Walsall, and we are board members of Walsall Together.
And last but not least, I'm Marianne Davey. I'm the head of the Black Country Insights Academy, which is an insights and intelligent function to help with all levels of decision making, from strategic, tactical and operational.
And most importantly, Marianne is in charge of the clicker.
This is a danger. I don't know why they've put me in charge of this, but I am, so I'm sure it'll be fine.
All right. Well, we'll have a good session today. Panel, we're very happy for Q&A as we go along. We've got sort of various different subjects that we're going to be talking about. But the overall aim of today's is that we're going to be talking a little bit more and understanding what's been going on with Black Country ICB and very much their approach towards innovative outcomes-based place commissioning. A lot of focus on delivery of population outcomes, strong population outcomes, and we're going to hear from the rest of the panel around the work being done with Walsall Together, which is certainly, in my experience, if we can bring something to life for you and show you a real life case study, it sort of resonates a little bit more than just sort of the theories of what outcomes-based commissioning is all about. So, as I said, very happy for Q&A as we go along. If you can't hear any panel member because these mics are only for recording, then please do shout. We've got a good hour and 15 minutes, so plenty of time. And our first speaker is you. So Marianne,
in charge and
tell us why an outcomes-led approach matters.
Okie dokie. So you'll be pleased to know it's not death by PowerPoint. I've literally got 2 slides, so hopefully everyone can see those. I feel like Sir Bruce Keogh teed me up a little bit, and it's almost like I don't know whether we've shared notes or he's seen mine, because one of the things I think to set the context of where this all started for us, obviously there's been a lot of talk for a number of years about population outcomes, how do we deliver outcomes, but I think really it was that first going back to we talk about this, but then we talk about we inevitably go to where 80% of our funding is spent in 20% of our funding is spent in really intervention piece, isn't it? So this is when I go do numbers and Adam looks at me and goes, don't do numbers, just do the context. So from my perspective, this was very much about how do we start to understand and measure consistently outcomes and start to deliver it and shift the focus away from interventions, be they from a health perspective, obviously in acutes, etc., or with any of our other ICP partners. How do we move it away from intervention into wellbeing and prevention? So that was very much the focus. And really it was understanding how do we all work together. Now, from our perspective, we were fairly clear, weren't we, in terms of when we first started. Walsall were already looking at how they wanted to bring in a well-being framework. So we were really on board with that from an ICB perspective, because it is very much about collaborative working. So when we first started looking at this, obviously we had so many measures in the intervention and management space. We needed to look at how we brought this more forward, but also how we enabled the ICS framework that had come out around ICPs and around ICBs and finding those roles, because I don't know whether it's the same across everybody's system, but understanding where place-based partnerships and ICBs and ICPs play their parts and how we all work together. We needed something of an enabler to work about that. So when we were looking at how we set up an outcomes framework, it's also how do we set up something that enables those partnerships to really add value and collaborate across the piece. So we started looking at the value of the wider determinants really in the wellbeing piece. So we started developing an evidence-based review to understand what was important to people's wellbeing. And although we wanted to focus on the evidence, and I can read through a few, so we've got things like meaningful connections, meaningful activity, access to transport, things that we know are wider determinants are important. I think we'd have probably all, and certainly guys on the ground from Connie's world and everyone else, would have already called a lot of those already. It wasn't just about the evidence for us. So with the Walsall team, it was very much then around understanding how do we co-produce this, how do we get representative groups to start adding the real person flavour to this as well. So we started using the evidence base to identify the drivers around wellbeing, and then started to understand from a person's perspective, from representative groups, how much did the evidence actually fill in the gaps, and what more did we need to understand. So we've then been able to take from wellbeing, from the evidence, and from a co-produced group of folks that helped us develop this, moved it through to KPIs. And I think of all of these, in terms of the outcomes framework, that is for me the real magic of this, focusing on wellbeing. But just to mention in the other pillars, I knew I shouldn't have this. I knew I'm far too. I mean, the fact that I have to sit down to do this is also a problem, because I'm very much one of those speakers that likes to stand up. So the other element here was then prevention, and I think we all talk about prevention, and prevention is one of those words for us which it can mean lots of different things to lots of different people. So in terms of our framework, we very much focused on prevention being the removal of barriers. So yes, there is a focus on deprivation, and we've used the indices of multiple deprivation as the index here, and we've used that to identify the KPIs. But it's not prevention in terms of where we're looking at wellbeing for preventing and providing better health and happiness. The prevention is really in this scenario for our outcomes piece is very much about focusing on removing those barriers. Regarding the management and the intervention bit, that's very much then around how do we relieve people from their conditions and from in terms of primary care, predominantly around management, but it's not just primary care, it's a whole host of services that support that. And then through into the interventions, which is really, in terms of the framework, looking at this is how we reduce the need to have interventions. So in terms of those pillars, kind of, it's almost the full stream from wellbeing and prevention, which cuts across all of our ICP members, all the way through to management and intervention. So that's the context. The real value of this, though, as helpful as this is understanding how can we consistently measure across the system. So as much work as we've done with Walsall, and it's been very important, part of the value for us as an ICB is also being able to consistently understand and compare, not from a competitive perspective at all, but compare population outcomes across each of the places that we have, because it's only by having that consistent language, that consistent measurement, that we can start having equity of outcomes. And that was a real driver. Touch that microphone, haven't I? That was a real driver for us in terms of it is about delivering equity of outcomes. The important piece, however, is that the places have their own infrastructure, their own autonomy, their own relationships with the VCSEs. We'll hear about all of the individuality elements that feed into that from a place perspective. We didn't want to lose those. That was very important to us as an ICB. We want to celebrate that. That's what makes those things work, and that's what they're very proud of. It's about us understanding how we can enable that and have that consistency. The other thing I wanted to touch on in terms of why it's important to have a consistent population outcomes framework is it is also about being able to talk about scalability. So in terms of, do we disinvest? What do we want to promote more of? What is supporting all of our population to get the best outcomes? How do we understand that we can do that? Well, we've all, I'm sure, been tasked with business cases and evaluations and papers. The real value of this is being able to take, and this is where I wish I could stand up, being able to take the initiatives that we have across the 4 places, and we'll talk about some of the Walsall ones, and being able to relate them to population outcome KPIs. So in this, for example, if this is a diabetes one, so we would look at, for example, physical activity of children in after-school clubs. We will be able to understand what are the initiatives, and it doesn't really matter whether they're innovative starting projects or whether they are full-blown initiatives with millions of pounds behind them. The important thing is having smart objectives, which I'm sure everyone's very comfortable with, and understanding how these relate to those KPIs. And the methodology we've been able to look at is the proportion of the population that we're helping with those initiatives, whatever the scale might be, and then understanding how that affects the proportion of that population of the KPI that we're looking at. So in this case, it might be prevalence of diabetes, but it could be if we were looking at meaningful activity, which from a wellbeing perspective, Love it when the button works. Going back to meaningful activity, it was very, very clear from the evidence and from our population feedback that it was around having something with a purpose. So it might be work, it might be volunteering, it could be a mix of things. So we would look at a KPI around workless households, the percent of workless households. We could equally take a project that looks at CV support and employment support and understand how we are affecting a KPI around workless households. So it's the magic for me in terms of this approach is being able to take the initiatives that we have and understand a direct link to population outcomes, but consistent measures that relate to all of these drivers here for wellbeing prevention and then management intervention. The other thing to point out in terms of why it is key, apart from the scalability conversation, is it's a difficult task to look at population outcomes and see any impact over time. Partly because outcomes obviously take, especially if we're talking about scalability, it takes a huge amount of money and resource to really make a dent in some of these outcomes. It also makes a difference in terms of understanding the macro influences. We don't, obviously all of us don't do transformation projects in a bubble, let alone ongoing initiatives that we want to scale. And I use this example quite a bit. In Walsall, one of our main employers is HomeServe, a significant employer in the area. If that goes bust tomorrow, heaven forbid, but if it did, that outcomes KPI is going to shoot completely, and it's going to have nothing to do with any of the initiatives that we've worked on as a wider partnership at Place. So the key bit here is understanding and hopefully getting our executive teams and funders and regulators to understand outcomes will never be tracked at the same pace as projects or initiatives or programmes. So we will, it's a bit like the inflation graph, isn't it? It will be really varied, but over time you'll see that growing trend. The key bit is understanding the short-term measure and am I influencing, am what I'm doing, am I making an influence on that outcome for our population? That's the key, and being able to evidence that is key. The last thing to talk about this, and again, thank Sir Bruce for linking me in with this, is the return on investment or using resources efficiently. So again, looking at how we do this as a group, understanding, and we're just at the start, I don't want to say that we've cracked this at all, but we're just starting to understand in terms of all of these measures, having that consistency starts to enable us to understand we can now put monetary value to these things, which that's not the reason we're doing it. The reason we're doing it is to improve all of these elements of our population's outcomes. However, ultimately, understanding that economic link that Sir Bruce was talking about, where we might invest in, for example, physical activity of children's clubs, and how that will make a difference and contribute to the wider socio-economic and environmental outcomes that we're also trying to drive as local authorities is also really, really key. So we can start to make those tangible links that brings everything together for all of our partners and removes really the focus on health inequalities, which is spoken very much about when we talk about population outcomes in this, and broadens it more to inequalities across the piece and how we can improve population outcomes beyond health. So that's, in a nutshell, why it's important.
Thank you. Two themes that, if you wouldn't mind, just talking a bit more about those. Use of data within you're doing within your ICS, and I'm conscious that potentially there's a tension between at ICS level and what you within the ICB want to do, think is the right thing to do, but then your focus on the place-based commissioning in your 4 places. How do you marry that up? I mean, are we saying that there might be this is our sort of our overarching plan intentions for improving the outcomes for our population, but within each of our places, and I know we're going to hear a little bit more about Walsall Together, are you allowing those places to sort of be in charge of their own population destiny, and what are they doing differently to one another?
And I think that's and that's why I've jumped back to this diagram, and sorry for, I said I've only got 2 slides, but I'm going to absolutely milk them for all they're worth, clearly. So I think in response to the second part of the question, I think absolutely that autonomy and the infrastructure that is relevant to those places is absolutely key, and I think it's, I would hate to imagine that any ICB feels that they would want to direct any of that, and certainly separately. And the apps, I definitely know you'd have a view. So I think the key piece there is understanding, firstly, in terms of to answer to your question around setting priorities, that's very much around the places, and because they will understand their populations. And it's not just data, I suppose, to answer your second part, and this is where I do get a little bit nervous from an insights perspective. Data will only ever tell part of the story because there's so much inference around it, there's so much around the people that need to feed into this. So for my part, as much as the data is key, so where you can start to use all of these KPI metrics to highlight where there might be priorities or where there might be issues that we want to focus on, it's really important to me that place and that element of engagement and involvement is also leveraged really, really keenly to understand the reasons and the rationale and the detail behind all of these KPIs and why these things are. And inevitably, and I know we'll absolutely hear about it later, it will be about, from my perspective, it's very much about all of the lifestyle and the challenges and the barriers, which is why, as key as it is to bring in things like prevention, and it's more important to focus on the positive element of well-being and how we can provide for our populations as well. But they are the ones best placed to understand that, and that's why it's so important to bring in that element. So yes, there is a data element and absolute consistency, but it's also about the insight that we can get from our populations and our groups.
You wanted to come in on that?
Yeah. So I think it's just worth noting, we recognise that the maturity and development of place-based partnerships is incredibly variable across the country, and it's no different in the Black Country. So certainly in Walsall, we've got and you will hear, we've got a really good relationship with our local authority, and we're very well aligned to the Health and Wellbeing Board. So we have a huge driver of our local priorities comes from the Joint Health and Wellbeing Strategy. That's not necessarily as well established everywhere. And I think the ICP does have a difficult job to do in trying to support the development in areas that need more support and kind of help them to identify some of those priorities that they perhaps need to be looking at. And that's not necessarily exactly the same in every area, and I'm sure that's replicated around the country as well. So bearing in mind that the ICBs are also fairly new in terms of how well established they are, it is an ongoing conversation to try and find that balance between system and place, and we're certainly not going to sit here today and say we've absolutely nailed that. We just hope to give you a flavour of some of the work that we're doing in the art of the possible. So I think there is still really positive conversations going on between system and place around how priorities are going to be set. And we absolutely recognise in Walsall that we do need to acknowledge those kind of national and quite often NHS top-down driven priorities, and we do our best to answer those, but we do absolutely make sure we've got that balance with our Health and Wellbeing Board and the wider partnership objectives at place. So I think in answer to your question, it's an ongoing conversation, but we're heading in the right direction.
Great, thank you.
And can I mention one more thing? I think the other added advantage of this is in terms of helping the ICB find that tricky balance that's been set out in the ICS framework around support and assurance, albeit very, very kind of broadly worded. I think this enables that assurance on a consistent footing, but it absolutely doesn't derive dictate in any way how these things should be done. It doesn't say which projects, it doesn't say how, none of that is absolutely stipulated. What it does is understand the relationship between the initiatives that are being done and how that serves the population, which is what we're all trying to do. So I think it helps enable that ICB role as set out in the ICS framework, but absolutely supports those places in doing that.
Great, thank you. Okay. I'm happy to take questions from the floor for the panel if anybody has a question.
So my name's Arlene, I work for IQVIA. I am basically a healthcare consultant based in the NHS. I've spent the last 20 years in the NHS doing a lot of similar stuff. So I used to be head of transformation for NLR, Leicester, Leicester and Rutland, just over the east side. And one of my, I suppose, experiences is that setting out the outcomes framework sets out a desire, doesn't it, of where it is you want to be, and a great understanding of what the variation looks like across the piece. Something I think definitely NLR, and I've no doubt in other systems, really struggle to do, and I'm really keen to understand if you've been able to crack this in any way, is we know one of the biggest challenges is NHS funding, like local authority, running on that fiscal year and the allocation of, and being able to make commissioning resource allocation decisions on the back of an outcomes framework is something that's what I've never seen happen, if I'm honest. showing attribution of initiatives to the achievement of that outcome. I don't know anyone that's been able to do that. Everyone knows what it is that we want to do. We understand the variation across the system. Places have their nuances. Showing that as a picture is great. Then when it comes to resource allocation, and ICB commissioners are having to make decisions, strategic plans against an outcomes framework, how do you crack that? Have you been able to use that as a lever to change commissioning decisions?
So
could I just check? Could everybody hear that question?
Ben's already told me I've got to repeat these, but I'm not very good at doing what I'm told, so I'm doing my best. So I can answer that from an ICB perspective. So in terms of the question, have we cracked using this outcomes framework to drive commissioning decisions? I would say we are on that journey. So the positive side for me is that from a joint forward plan, we are really clear that using the population outcomes framework is how we want to move to. So we are setting our measures against the population outcomes framework for our joint forward plan, and correspondingly how we want to commission will ultimately be there. I think in terms of maturity piece, and I want to bring you guys in as well, but in terms of maturity piece, I would say no, being really honest, I don't think we're there yet. There's absolutely the ambition, and we've now got the data and the measures, which I think gives us that. So in terms of a pretty picture here that says here are the drivers, etc., where do we want to go, that's only 20% of it really, isn't it? I think the really key bit here is understanding, right, and these are the measures that we need to ultimately drive. And like I said, understanding how those initiatives feed into that. So we're talking with our strategic commissioning committee about how we use this in these measures to be able to do that. So that's definitely the ambition. We have the measures, which I think is the kind of key bit of the puzzle that's probably been missing previously. But no, I think it would be unfair to say that we've absolutely cracked that.
Thank you. Kerry, you wanted to come?
I was going to say, yeah.
Okay. Yeah. Just let Kerry come in, then we'll come back to you.
I think what we have been able to achieve in Walsall, certainly, and it's been now considered at various stages across the rest of the Black Country, is it has to be a continuous conversation. So you can't just set outcomes and then resource allocation in one meeting on one day. You know, it has to be a continuous conversation, and you have to create the environment for that conversation. So you've got to have the relationships, you've got to have the trust, you've then got to have the forums in which you're able to have those conversations. And thankfully we have a lot of that in place in Walsall. So actually when we got another tool that we can use to strengthen that conversation, then it's easy because we've already got the foundations in which to use that tool, if that makes sense. So the Wellbeing Outcomes Framework, it will be embedded within the council plan, it's embedded within our commissioning intentions, and similar organisations across Walsall will be using it in a similar way. So it's not just a one-stop shop, this is what we've got to allocate this year, what outcomes are we going to allocate it to? It's, this is what we want to achieve, these are the outcomes we're going to achieve, and that, as I say, it feeds into and comes out of the health and wellbeing strategy and our strategic director.
Yeah,
thank you. Did you want to come back?
I was just going to say, whilst I asked a question, the answer was no. I don't want to lose the pertinent point that you just made, which is using this as the backbone of integration and collaboration is actually a really, really bloody hard job. You know, having big organisations, multitude of organisations hang their hats on one single thing as an ambition is really hard to do. So the fact that this would sit in your health and wellbeing strategy, would sit in your commissioning intentions, would sit in your place-based plans, would sit in your 5-year forward view, these are all things. Hence, this is so hard, isn't it?
Yeah.
Because you're reporting different plans and different commitments to multiple arms, which is why actually making stuff happen is really hard.
Yeah.
So the fact that you've got a single version of the truth
and isn't just health related, or isn't just, I think that's the key, you know, kind of element for me, and actually moves away from, which I kind of fumbledly kind of explained at the start, moves away from that intervention, right, we've just got to tackle the immediate kind of problems. It's actually trying to pull, so in terms of the Hewitt review and everything else around the 1% around prevention, it's actually whatever word we use, prevention or other, it's moving all of that funding upstream, as you said, in a coordinated fashion, but it's also looking at those multiple drivers which extend well beyond that. I mean, access to transport's on there. We can link it to health, but we could link it to all sorts of things. So that one version is because it speaks to all of the partnership, I think, is key.
Michelle, you wanted to come in, and then Connie.
So I don't for one second think that we could do this if we don't see something change nationally in terms of the way providers are held to account. However, this is one of the areas that I get most excited about in terms of my day job and some of the work that we're doing, because I do think that the tool we've got, and I'll talk a little bit more about the journey on the wellbeing framework in the Walsall Together section, but there's a huge evidence base behind it and some input from citizen voice that drives how do we go from those kind of day-to-day KPIs, as I would call them, the operational stuff that we're all held to account for, and how do they map against those outcomes? And we have really good commitment actually from the finance and contracting team in the ICB, who see our desire to move to outcomes-based contracting. We have an SDIP, without getting too technical, in our community contract this year to help that transition towards an outcomes-based contract. So I don't yet know for definite, I don't think it'll be there on the 1st of April next year, but there is a real commitment across our system to try and do this and to keep developing this tool so that we can actually evidence upwards. Yes, okay, we might be missing a performance KPI over here, but look, we've got proof, real robust proof here that we're hitting outcomes for people. Therefore, don't worry about that one little KPI, because as a whole, actually, we're doing the right things for the right reasons. And that is, you'll see when we talk about Walsall Together, that is the culture that runs through our partnership. We all come together and do the right things for the right reasons. So this is absolutely a tool that I'm really excited about, that's going to get us where we want to be. But the where we want to be and how we work together is what actually drives improvement in outcomes. And there is a commitment definitely in Walsall, and we're seeing it across the ICB now, to understand that and try and work collectively to get there.
Yeah, I was going to say, as somebody from housing, social housing, we're about to do our corporate planning, and this will be very much driving the work that myself and my colleagues do in my service area. So to have an evidence-based outcomes framework that non-health people are signing up to, which is then real population health. So and I've been on the partnership for about 5 years, and it doesn't feel like it's health, social care, community voluntary sector, housing. It's the partnership. And what I love about this outcomes framework is that some of the people that live in my homes, some of those core 20 people, contributed to decisions about what was on there. You can't get more pure than that, really.
Thank you. No, that's great. I just suppose I wanted to come back on a couple of things. So one of the things that we were talking about in the first session, the first panel this morning, two things that stuck out for me and what panel have been talking about. One is, what is integration, and everybody interprets it differently. Well, goodness me, isn't that integration at its finest? Gold star, go to the top of the class. But also, I think it was Naomi that was talking about, don't assume what your population want or need, ask them. And it's really refreshing to hear that, the people that you're talking about, they've created this, they've co-created this with you. It's another gold star, well done. Okay, thank you. Sorry, just one, is there anybody else with a question on what we've just been talking? Yes, lady in the orange top.
In terms of local authorities, really, because, we know that many are facing a very difficult time, and there are many decisions about really just focus on key legal priorities. This is going to be tough in his work, and what I worry about is something that is potentially slipping through that net and isn't going to be considered as essential legal services, and our view on it is perhaps not. So what are your plans around the reality that we've got quite a few councils in the next few months? What have you already prepared for us? They are literally on that trajectory. So where are we going with that in terms of that?
Okay, I'll try and do as I'm
We're all going to let you carry on.
as I'm told. which is to repeat your question. So I suppose what you're asking is it still a priority when councils are facing really difficult financial challenges? And the answer is yes, it has to be. So no one organisation can operate in an area alone and seek to achieve good outcomes and good value for money at the same time. I know that if I leave somebody in a hospital bed a minute longer than they need to be, they're likely to deteriorate, and those costs are going to end up sitting on my balance sheet. I know that if I don't engage with my voluntary and community sector in a meaningful way, we're going to be doing a pile of stuff in very heavy health interventions, social care interventions that could be done more cost effectively in our communities by the community and voluntary sector organisations. So I see this as absolutely fundamental to balancing my budget, and my council support that, thankfully. But it has to be meaningful. If I operated in one of the previous systems that I've operated in, where you hear the chief executive of the hospital trust saying those bed blockers, you just need to get them all out, put them into £1,500 a week beds. Quite frankly, I'd be digging my heels in and going, do one. Sorry, that's recorded, isn't it? Oh well.
Could have been worse.
Yeah.
Could have been worse.
It could have been worse. But it's not like that. It's not like that in this system because of exactly what Connie just said. Yeah. It is a true partnership. There's equity in the partners. I can trust the chief executive of my local acute hospital to talk about social care in a respectful, meaningful, equal way. And I think that's really important in terms of that partnership working.
Thank you. I think did I see one hand go up previously? Yeah, it was yours.
Thank you. So, George Ali Bobart from Health Innovation KSS, you might have known us as AHSN in the past, so
right.
Space. Again, echoing what was said about this being really hard to do, something that was mentioned earlier in the previous sessions around equity. You mentioned equity of outcomes being one of the things that we intend to achieve through this tool. I suppose one of the challenges is understanding what the unmet need is and how you address that unmet need. How does this tool help you identify inequity of access to then enable you to get that equity of outcomes prospectively through various methods and so on? I haven't seen anyone who's cracked it yet, but just was wondering if that's within the scope of the work and the tool.
I feel like I've got plants around the around the place. So this does link in. So in terms of repeating the question, how do we identify inequity of access to then promote equity of outcomes? I would say the tool itself does not do that. And the tool will, because it will only measure what we do. And I want to bring you guys in. I suppose the one thing I did want to mention from an academy perspective, from an ICB perspective, providing our places with that insight as well as the insight they already get from their communities is really important. So in terms of understanding unmet need, one of the ambitions that we have, because you're absolutely right, understanding where there is unmet need is going to help us further refine where we focus, etc. And where that variation needs to be reduced. We're looking at how we can bring in effectively more of that market research, broader insight into things. So as much as the involvement and engagement work with specific communities is really, really key in understanding their needs, in terms of then getting the converse and that breadth of insight in terms of when, for example, someone's looking at, I don't know, a particular childhood disease that their child might have been diagnosed with, etc. Understanding what they're Googling, what they want to understand, what support groups are they going to, understanding where people are trying to self-serve almost, and find those things, and how we can help address those is one of those insight gaps that, from my perspective, in terms of the academy, I feel we really want to focus on. So I don't think the tool is going to answer that in itself. I think it's going to be all the work that these guys can talk to in a minute with the groups, but I think there is also a support function that insight and intelligence groups can, organisations across the system can provide as well. But I think you guys can probably talk more to the people element of that.
Yeah, so I was going to say, I think there is some information, really useful information in there about inequalities. I mean, I'm sure if anybody wants to kind of follow up with us, there's a whole load of stuff that sits behind this that's worth drilling into. We are limited, obviously, by data that's available to us, but actually the data that we do have is quite significant and quite vast, and it covers kind of publicly available NHS, QOF type data, but we've also mapped in housing, DWP data. So actually you can start to look at things like where are our care homes in comparison to other indicators, where are our children with under fives in comparison to other indicators. So actually I do think we've got some really good insight into inequalities limited to data that is kind of out there and available. And I think there is some work to do with multiple partners around collecting more data that would give us more insight. But I do think that we're onto something in terms of not necessarily having new data, but it's how we bring it together and how it's displayed that actually starts to give real insight. And I don't know, Connie, if you want to kind of talk about what it's done from your perspective, because what you can see against your housing stock is where you've kind of seen some added value.
Yeah, so we're really fortunate to use some a platform that this gentleman over here is leading on, which allowed us to overlay the postcodes where our homes were and then determine whether they were part of the core 20 population. And what a surprise, 82% of the homes that my organisation own are within a core 20 population area. But what that's been able to do from a real health perspective is about 4 years ago, a little boy called Hakeem died of an asthma attack, and that piqued my interest to say, does he live in social housing? Yes, he did. He was from Birmingham. Was he disadvantaged? Of course, yes, he was. So I then used View-It to look at where our children lived that were going into the local hospital with asthma attacks, which were avoidable and was a result of all the wider determinants rather than a clinical reason. That's allowed us, so that's an unmet need at the moment, but actually using the data, using our connection with our customers, we've been able to start a relatively small proof of concept where we're bringing in health, housing, communities, data all together to reduce children going into hospital for avoidable asthma attacks. And I saw the consultant paediatrician last week at an event that we were doing, and she said to me, the one little boy that we started the work off with, he was going into hospital on a regular basis. He still goes into hospital, but massively reduced in terms of the episodes that he had now. Health can't do that on their own. I can't do that on my own. We can't do it without the data. And that may drive a national policy around asthma-friendly homes, and that's all from this partnership. Yeah. So the solution is the partnership working together.
And I think that's probably what I meant. The tool itself, in terms of measuring the KPIs, is never going to do that. It's all of that good stuff. I think it's and I am quite self-critical when it comes to this as well. So yeah, but it's all that work that makes that difference for the variation.
Kerry, you wanted to make a final point.
Just reiterating that point, in that I suppose the person that isn't here, and we would have got a double gold star, is our colleague that works very closely aligned to us, Jan Davis. She's the chair of our community resilience group. She is the chair of our local community associations, so she works in the community and voluntary sector. Again, she's a fully fledged member of our partnership, and actually quite a strength in our partnership. And what's important is this tool doesn't give us all that information. It doesn't tell us where that unmet need. Jan does.
Yeah.
She absolutely tells us where the unmet need is, because she works in communities, she represents communities, and so she brings that information to us. And then we can then go about validating that information. So we can use something like this to go, okay, what can we measure? What can we measure in what you've told us that will give us the intelligence that we need to go and tackle that unmet need?
Yeah. Thank you. I know there were a couple of other hands up. I'll just take one more question, then I want to move us on to talk about Walsall Together. Gentleman in the back.
Well, I might have a question for Walsall Together. I want to give you your talk. Whatever you do, don't be changing your names ever again, because that confuses. I mean, my name's Darryl Mayer. I'm a community campaigner and patient. It's great that now you've got a set of KPIs and a foundation for something to build upon. Now, I've attended a lot of people's panels throughout Sandwell, and they've been very active. And the ICP have brought a new energy, and keep fingers crossed that continues. But I've also attended health and wellbeing board meetings at Sandwell Council, and it's clear that whilst there are some officers with some of the organisations there know exactly what this is all
There's not necessarily a political buy-in at all. So it's getting this information out to those elected officials. But one of the last health and wellbeing boards that I attended, we were talking about the IC, and it just seems like a new presentation soon in there. We were talking about these developments, these plans, and there was a councillor that he hadn't got a clue about care navigation. He wasn't aware of what social prescribers were. And what he did was he took it from that meeting to make have a working group to have a look at how we could promote what these things are. Now there's 72 elected officials there, and they're the voice, supposedly the voice of the community. They need to know this. In Warsaw, Sandwell, or wherever, throughout the country. And you can sit down the elected officials and go through and present it to them.
Thank you. I think that's on your to-do list, is it?
I can just do a general response. I can't talk to Samuel clearly, but I suppose I'd just challenge ever so slightly back to say, why do they need to know? Ultimately, if the outcomes that are being delivered are good outcomes, if when somebody picks up the phone they get the right response at the right time from the right professional, if they get the support that they need in their communities, actually, it doesn't matter whether Michelle turns up or I turn up on that person's doorstep, they're getting the outcome that they need. And so I'm being a bit facetious there, but of course people need to know about it and they need to know what the infrastructure, but most elected members don't even know what primary care means, and they don't know that GPs are not employed by the NHS directly. So I suppose it's just making sure that they've got the right information to give to their residents to ensure that they get to the right place at the right time, isn't it?
The reason why they need to know is because legally they are responsible for
Absolutely.
paying money. So the gentleman's absolutely
Yeah.
correct. They do need to know, and they need to know because ultimately they sign things off. So it doesn't matter what everybody else is doing. If they decide that they're going to sign off, it's not going to get signed off. You're absolutely right.
Yeah.
It also makes your routes
Absolutely.
a lot easier.
Yeah, it does. They do.
Did you want to comment on that?
Yeah, so I was going to talk about it from the kind of health side. So obviously, you'll hear, we do work very closely with our council in Walsall, but I think there's something around the shift that we've seen since the creation of ICSs that has it was almost a distraction, wasn't it, for us? Because our partnership was established long before even the white paper. And all of a sudden there's this huge focus on kind of structure and governance and this need for integration and partnership working, but it's almost it's kind of dictated to people. So there's this NHS structure called the ICB and this massive operating model, certainly in the Black Country anyway, but I've seen them from other areas. And it's almost like we have to work in partnership. So local authority, can you come over here and join all of these meetings, please? Because it's really important that you help us to do our job. And sorry, Marianne.
No, I don't take that personally. So it's not me saying it.
And I think there's something really, really important at all levels, right from national policy. And I'm kind of trying to contribute in part to the major condition strategy at the moment. And this is coming through really, really clear from all place-based partnerships. It cannot be an NHS construct that you sort of tell your local authorities partners you've got to be part of. The reason places like Walsall, and we're not alone, there are other really good examples around the country, do it well, is because it started from truly joint working. So when I talked earlier on, our priorities and our outcomes are set jointly between health partners, local authority, voluntary sector. We don't kind of say, well, there's an NHS agenda over here and how can we deliver that jointly? We don't go to our voluntary sector and say, we've got a problem with access in this community. We'd like you to do X, Y, and Z to improve it. We're like, actually, we don't really know best about everything. Who out of our partner knows how to solve this problem? You lead on that and we'll help you.
Actually, a concrete example of that is that I chair the Resilient Communities work stream, which is the prevention, health promotion, health equity. And that is because my background's community development. I've worked in disadvantaged communities for over 30 years. And the partnership recognises that our connection to that core 20 population is so much stronger than somebody else, another service. So there isn't that preciousness that there is sometimes in partnerships. And I would say the most important thing about all the work that we do is relationships. It's all built on relationships and trusting people. And the gentleman up there, you're right, the relationship with local people for this model, anybody that this impacts on needs to have that understanding so they can buy into it. Because then everybody that should benefit from it benefits from it.
Thank you. Okay. Pause it there. I would like, if you wouldn't mind just holding that thought, I'm just conscious of time. I would like to move us on, and Michelle, you're going to talk about the Walsall Together. Thank you.
Do you want the click? It's a big respect. Okay. Oh God. All right.
I will have it if you want me to.
No, it's fine. I can. No. I can absolutely. You do the whole next slide thing. It's fine. I can do it.
The Chris Whitty thing.
Absolutely.
So we've covered some of it. So I'll kind of talk through some of the slides. Kerry, chip in if you want to on any of the kind of generic slides, and I know you'll talk about with Connie some of the specific examples. So the point of this bit of the presentation is we wanted to just give you a flavour of who we are in Walsall, our integration journey, and really what makes it work as well as it does. So you've heard the kind of more technical stuff around the outcomes framework, but just wanted to give you a flavour of the other things that make all of this happen. So
seamless.
Thank you, Marianne. So this slide has obviously got some of the references to the King's Fund, and there's lots of information out there that is actually really good in terms of describing what place-based partnerships are, the potential benefits of operating at place level. And from our perspective in Walsall, we do have those long-standing relationships, particularly between the hospital trust and adult social care. But ultimately, we come together in quite a broad partnership with a single focus on improving the outcomes for our local population, and we are aligned to those democratic structures in the council. So I can't see this slide from here. But we are a place-based partnership. Our membership includes so the local integrated health and community trust, the mental health trust, local authority, which is adult social care, children's services and public health, our housing partners, voluntary sector is represented through our community network and an infrastructure organisation, and we have Health Watch, GP practices, and I hope I haven't missed anybody from that list. And so we operate under a host alliance structure, which means our governance is just hosted by the hospital trust, just to give it a home for the governance, but we have an alliance agreement that all partners have signed up to, and that very much, it's not a legally binding document, it's a behavioural document that describes how we work together and our shared aims and objectives. The very colourful circles that you can see on the slide is our integrated model of healthcare and wellbeing. So very much at the heart of that, the purple circle is our communities and where a lot of our resilient communities work happens, and then you go outwards kind of through the tiers of care, as we call it. So you've got primary care, long-term condition management, integrated working in the community, through to intermediate care, crisis management, admissions avoidance, and then the very outer ring represents the kind of acute and bed-based hospital services. Thank you. So as I said, partnership working dates back probably more than 7 years. Kerry will know better than I do. But in kind of 2018, we set out a case for change and started to work on a formal business case that would establish Walsall Together as kind of that formal partnership. So this slide describes the ambition that was signed off in early 2019, and that was signed off by all of the statutory partner governing bodies. So we were ambitious, we wanted to stand out from the crowd in terms of that integrated model of healthcare and wellbeing. It was evidence-based, international and national best practice around integration, but felt quite kind of pioneering at the time. There's a real strong focus in there around addressing the wider determinants of health, increased focus on prevention and early intervention, so you can start to see how that focus on outcomes was coming through. And the kind of final 2 points on there around collaboration around commissioning, contracting and governance, I'll start to talk about. But they were very much, how do we make those work for the partnership and what we're trying to achieve? So that focus was on shifting resources upstream, shifting things towards prevention. How are we going to do that together? And then once we've sort of worked that out, what's the governance that's going to help us to do that? And then ultimately, which is kind of where we're just about coming on to, sorry, Rhiannon, I'm putting my hand in front of you, but that movement towards population-based budgeting and more pooled budgets, delegation of responsibilities at place is kind of still the ambition now. The top right of your screen is actually our original outcomes framework. So we very much had that at the heart of our original business case, and what Marianne has shown you early on is kind of the evolution of that today. And the bottom right is our current partnership aims. So we very much set ourselves up along the lines of the triple aim that most people in the room will be familiar with. So improving outcomes, quality of care, and importantly, making best use of our collective resources. We've since added a fourth, mainly through lessons learned during the pandemic, to give focus to our workforce. So this page is kind of a refresh. It's not the exact ones you would see in our alliance agreement, but it's the principles that we work together. And this list was actually updated about 12 months ago when we were looking very specifically at the place-based governance model that was kind of asked of us on the back of the creation of ICSs. And it was very much to make sure we stayed grounded in what we were all there to do collectively. So how do we make sure that culture defines what we do and not kind of structures that are imposed on us? We collaborate as default. So I know today the focus of the session is around outcomes-based commissioning, and I think there's a lot of debate happening across the country now around what commissioning is, whose responsibility is it, where is it done in the system. So for us, there are clearly people who have commissioning in their title, and there are organisations with statutory responsibilities for commissioning. But actually the processes that you would see in the commissioning cycle, so service planning, redesign, all of that detailed work is absolutely done in collaboration, and our governance structure supports that. So we have boards with commissioners on that ultimately sign off decisions, but actually the work is done with absolutely everybody in the room, and the same with kind of day-to-day operational things. So through the pandemic, and it has continued, we have what we call daily tactical meetings. So through winter pressures or the pandemic, all partners get in a room together and solve problems and pressures in the system. And as well as the statutory services, people from Connie's team would be in those calls kind of daily or weekly, depending on what pressures are going on in the system at any time. So I won't talk through all of them. You get a flavour of it. And I think, Connie, you alluded to the bottom point around distributive leadership. So we identify who's best placed to solve any particular problem or to lead on any particular priority at any given time, and that partner kind of takes that lead. Thank you. I'm going to hand over to Kerry to talk around immediate care.
So I'm going to give you a real practical example, but before I go into this practical example, I just wanted to give a little bit more context in terms of where we came from. Just to say that the development of Walsall Together was very much evolution and not revolution. From the absolute outset. So I arrived in Walsall just over 7 years ago, and when I arrived in Walsall, there was already a board called the Healthy Walsall Partnership Board. And the Healthy Walsall Partnership Board included all of the executives from all of the organisations from across the health and care organisations, as well as the housing group, as well as the community and voluntary sector. And they would come together to have good conversations. Now, they didn't achieve the masses because it really was just about having really good conversations. But that's where the birth of Walsall Together came from. It came from good intentioned people with trying to deliver good outcomes for the people of Walsall, because that's what their common interest was. So when Walsall Together was developed, what we initially did was we looked at what the opportunities for integration were, and we came up with a very typical target model, which is the predecessor to that nice diagram that you saw on a previous slide. And that target model identified 4 main areas. The first was in regards to resilient communities. What can we do around prevention, early intervention, supporting communities to keep people well and independent in their homes for longer? The second was in relation to long-term condition management. So what can we do when people are starting to have issues, health-related issues predominantly, or social care issues? What can we do to keep them well for longer in their own homes? Thirdly then, okay, at the point of crisis, what can we do to facilitate hospital discharge in a timely way or prevent a hospital admission? And then fourthly, it was around how we coordinate the care navigation. How do we coordinate care across those tiers? So they were the 4 opportunities that we identified at that time. And intermediate care was almost the flagship. It was the first service, if you like, that we looked at as a partnership. And I'll just reiterate that where we started from is we want to deliver better outcomes. It wasn't the health trust saying, get these people out of our hospital damn quick. It wasn't social care saying no, because they're going to cost us £1 million when they come out. It started with actually what is the outcomes that we want to achieve for these folk that are either going to go into hospital or need to come out of hospital. So that's where we embarked. Now, interestingly, at the time that we embarked on this, I was a director of commissioning at that time. So I was approaching this from a commissioning lens. But I couldn't achieve it through a commission. I couldn't achieve it through writing a specification and putting that out to the market and saying, hey, can somebody come and deliver this? So actually I switched hats and I stuck a provider hat on and I went and did the transformation of the intermediate care service as a provider, working alongside our other provider colleagues to introduce this service. I'm going to jump a lot of pain, and it wasn't easy, it wasn't overnight, but what did we achieve? We halved the budget. So going back to the budget question, we practically halved the budget that we needed to deliver this service. And the reason we halved the budget is because what we realised is that at the point of review, we had 11 disparate services across that health and care space that were all trying to achieve the same outcomes, all with their own infrastructure, all with their own management structures, all with their own different levels of staff operating within it. So we got rid of all 11 and we created one single service. And as I say, we halved the budget by doing that. We were then focused on the data. We really looked at what is it that we really need to do in order to achieve better outcomes for these individuals. And we focused on 2 key indicators, which was length of stay past the point that somebody was medically fit for discharge, and then the flow and byproduct, which was getting them to the right destination, so home first approach. So we introduced that home first discharge to assess model before the national guidance was released. As I say, it was the first flagship project of the Walsall Together partnership. What we managed to achieve was, as I say, half the budget. We doubled the throughput, so the flow increased, as I say, doubled the flow. And we also managed to reduce the length of stay past the point of medically fit for discharge to 2 days on average now, between 2 and 3 days. At the point that we set this up, it was at about 10 days. So we've dramatically reduced the length of stay post-medically fit for discharge. But it was entirely around collaborative work, and it was focused on outcomes. It was using the resource effectively, so the right intervention at the right time by the right officer. Why have we got nurses going in and doing shopping for an individual to get them home? Because that's what's needed. Actually, let's work with our community and voluntary sector and get them to do the shopping for us. So yes, collaborative approach, achieved good outcomes, half the budget. Thank you.
I think we're going to go on to Connie now.
Yep. Yes, good afternoon everybody. So as I said, my name's Connie. I've worked in disadvantaged communities for 30 years, but I also grew up in a disadvantaged community. So my lived experience is my superpower, and I use that lived experience to influence decisions that I'm making on behalf of other people that are living similar lives to the life that I lived. So I've worked for WHG. We're a community place-based housing association. We provide homes to around 1/5 of the borough of Walsall, And because of the residualisation of housing, so when housing was first a concept, social housing, council housing, it was a universal service for anybody. But unfortunately, from day dot, we never ever built enough homes to give everybody what they needed and wanted. And so it very much became a targeted service. And what that then means is that the people that are living in those homes are allocated those homes based on vulnerabilities and risk factors and needs. So what you then get is a disproportionate amount of people with vulnerabilities and risk factors living in a certain tenure, which then means that those people are then going to draw on other services. So WHG is an anchor institution. We're a big employer. We employ about 850 people. And we do definitely recognise ourselves as a place maker and a place shaper and also a health maker. So within our corporate plan, we've got a distinct target that I have to achieve, which is to improve the health and wellbeing of up to 10,000 people, which as a non-health agency is pretty stark. And the reality is that our customer base is around 44,000 people, and at least a third of them are going to die on average 12 years before the national average that Bruce spoke about earlier on. So although we talk about people living extended lives, that's not happening on my watch. On my watch, people get to the age of 58, 59, and then they're faced with chronic health conditions which impact on the quality of their life. And what you'll also find, and that's backed up by research by Marmot, that social housing customers, despite having the worst health, have the least access to services. So the unmet need that you talked about is definitely within our group. So I call our people your people, because it's our people that are going to the GP regularly because they're lonely or in debt or have had a relationship breakdown and they've got no one else to talk to. And also they are the group of people that are presenting with either the core 5 or the core 6 areas that each geographical area focuses on in terms of poor health and well-being.
Thank you.
Lily said next slide.
I know you did. I was clearly not on it then.
So as I alluded to, I chair Resilient Communities, and why I'm excited about that, it's about turning upside down the health system. So we know that health outcomes, only around 10-15% are determined by the GP or the hospital that you go to. The other 85%, a small amount, about 10-15% on lifestyle, but the rest of it is what job you do, where you live, what education you've got, your relationships. All of those things are avoidable and they're unfair. I drove into Birmingham today, I live in Birmingham, and I could have said to you, I'm going to stop here, everyone here is really well, affluent and thriving. I then came to Labourwood. Everyone here is dying in their 50s and everybody thinks that's normal. That is scandalous that we have a system that is doing that to people. Next slide, please. So, our Champions for Change is all about using lived experience as a superpower to improve the health and wellbeing of the population of Walsall. So I'm really proud to say that in my service, around 50% of the people that work in my team are customers. Because guess what? The best people to reach those, the so-called hard to reach, are the people that are also described as hard to reach, because they're not hard to reach. We just don't have the tools in our professional frameworks in order to reach them. So 20 years ago, I came up with the Community Champion model, which basically recruits people from a geographical area that you want to work in, that have lived experience of the issue you're trying to deal with, and have cultural competency to be able to engage with the group that you're trying to engage with, and also have those natural networks. So when Naomi talked about being in a laundrette, she was so spot on. Most of my childhood was spent in a laundrette on a Sunday after Mass because we didn't have a washing machine at home. That's the context of that you need to take into account when you're making decisions around health services. So we use a theory of change approach. We work with people in the pre-contemplative stage before they've even thought, I need to do something different. And I always describe the champions as being a bit of a human bridge. There's the person over here that needs service. There's the service, massive gap in the middle because of low mental capital. And they take them by the hand and they take them into that service. But the other thing that they can do is turn the tap off. So a lot of people that we work with think they are mentally unwell. They are not, they are situationally unwell. So they go to the doctor because they say, I'm anxious, I'm worried, I'm scared. The doctor doesn't have the time to get that story out of them, so they get prescribed antidepressants. They then believe that they're mentally unwell because that's what the doctor's told them. So they then go down that pathway where actually they then think, well, I can't work because I'm mentally unwell, the doctor told me. And so that cycle goes round. So we can turn the tap off by spending that time with those people to give them that person-centred support, which is what they need, a social prescription rather than a medical prescription. Next slide, please. So what I would say there, working in partnership with these lovely colleagues here, is they absolutely recognise. Michelle said to me very early on that she thought she understood community engagement till she worked with me, and then she realised she knew absolutely nothing about community engagement. So it's a low cost approach to reducing health inequalities, right help, right time for the right person, as you said earlier on. Slide, please.
I'm getting it now.
Yeah, okay. So we use this model. It's a lift and shift model. You can use it for any type of issue that you've got. I've already touched on the asthma work that we're doing. If we look at diabetes, so in parts of our ward, we've got up to 50% of people that have got diabetes, South Asian. So we recruited a team of diabetes community champions. Between the four of them, they speak 15 community languages. They go to the religious places where their friends, families, extended relationships go. They are door knockers. So that person that doesn't come for their care and is at risk of having an amputation because they're not self-caring for themselves, that will be the cousin of the cousin of the friend who will then talk to that champion because you're not scary, that power imbalance isn't there. Mental health, our social prescribing service had an independent evaluation. 97% of the people that we work with were diagnosed with a mental health condition. When we actually got down to what the issue was, it was debt, it was loneliness, it was relationship breakdown. The social prescribing service that we offered improved the health of 91% of people in a significant way. And more importantly, we did a sample of that group of people and 100% of them reduced the times they visited their GP in a 12-month period. A champion costs about 22 grand a year, and we are well on our way to meeting that £10,000, that 10,000 people that have improved their health and well-being.
I'm going to stop there.
Okay. I'm just conscious, Ben's just given me the look that said there's only a couple of minutes left, and I'm sure there'll be a couple of questions. So we do have a couple of minutes, although panel, are you all staying for
Yes.
coffee? So
yeah,
if you don't get a chance to ask now, please do ask any of the panel over coffee or tea. Is there anybody who has a burning question now?
Brought up again about social prescribers and care navigators, and it's clear that the GP practices are still struggling to embed these and get these out to promote and make more people aware of it. But there's an issue around the patient voice which hasn't been brought up necessarily on this. There's obviously, through the GP contracts, there's a need for a patient participation group, and there is funding attached to that, depends on how, there's extra funding, depends on how far it goes. For me, I've been looking at this over the last 10 years, 15 years, and we're no further forward in getting active patient participation groups. GP practices and management might tell you that they've got one, but the fact of the matter is, it's a tick box. It isn't a reality. The patient voice and those PPGs need to be pushed. And the question is, if it's part of the GP contract, what will you do to enforce and push the GP practices to have an active PPG?
I'm happy to try and take it. I guess what we haven't got here is anybody who commissions primary care in particular. Yeah. However, I think what we do have is some really strong views on how to get the citizen voice into the work that we do. So we do work with our GP practices and the PPGs, but we also think that there are other ways of getting the citizen voice in that might be more effective in lieu of having those active ones. So I don't think we have any powers ourselves to kind of influence that part of the system, but we can talk to you about how we think we get the citizen voice into the work that we do in Walsall. And I think actually local authorities, when we talk about partnership working, local authorities and voluntary sector are streets ahead of the NHS in terms of how they engage with communities. And I think there's some lessons that perhaps the NHS, including kind of primary care could learn from the way in which they secure that. And actually hospitals don't do a bad job in terms of membership for citizens as well. So, but I don't know if Connie, you want to talk about your clever conversations?
Yeah, so the Walsall Together partnership recognise that we're much closer to those people that need a voice in decision making. So we're like a little army that goes out into Walsall, and we have what we call a clever conversation. So these are people that are role models or, you know, community activists, if I want a better word, and they will use coaching skills to have a win-win conversation with somebody. So we like, for example, we've just done a piece of work with Birmingham University around digital exclusion for disadvantaged groups, and what we'll then do is use those conversations. So it might not come to, my customers would not go to a patient participation thing or a panel, because if you think about engagement and consultation, my customers are over here with the worst health. The panels, I would say, are somewhere here when people have got the confidence, the skills, the knowledge to be able to participate in an informed way. So we do a lot of work in this space, the pre-engagement, pre-contemplative, and we do that by knocking the doors, and we do it by standing in school playgrounds, and we do it by standing in laundrettes, and we do it by standing in supermarkets. We go into the context and the environment that the people with the worst health are active in, and we have the conversations on their terms in that environment.
Thank you. We are out of time. Can we just show our appreciation for the panel in the usual way?